So, welcome to Strength and Kara podcast. This is season 3, episode 1, and really no introduction is needed for the legend that we have joining us, but I will. Okay, so welcome, Dr. Kelly Starrett, one of the most influential physiotherapists in the world. I am going to attempt to say a few things about you.
Oh no, don't do it. Just skip ahead.
Okay, I did this. I did this with Dr. Locke. I was really proud of it. I had a whole bio. I did a lot of research, and after I finished, she's like, "Yeah, and you missed it, and you missed a lot." So I was like, I was like,
Well, with Andrew, it's heavy. I don't mean to just usurp you here, but that kid has his resume is dense.
yeah, I think I missed like all his athletic achievements.
If you don't have great dancer on there, that's going to be a super bummer. So carry on.
He's certainly getting better at dancing. I'm not sure if he's there yet. It's a biomechanical thing, it's leverages. Anyway. So Dr. Kelly Starrett. So Kelly is the co-author of New York Times bestseller, Becoming a Supple Leopard, fantastic book, Ready to Run, and Wall Street Journal bestseller, Deskbound. The most recent bestseller, Built to Move. Kelly was also the co-founder of San Francisco CrossFit, the 21st CrossFit affiliate. Kelly consults with athletes and coaches from the NFL, NBA, NHL, NBL, US Olympic team. Elite Army, Navy, Air Force, Marine, Coast Guard forces, consults with corporations and employees on health and well-being. It seems like you do it all. And for those that are listening, like I said, no introduction is really needed because you're probably one of, if not the most influential person in the MSK physical rehabilitation space and have been now for a while. I mean,
oh man, that's nice to say. It's 100% not true. I'm going to call myself second wave, maybe even third wave if like McGill, I know he's not a physio, but Gray Cook, Shirley Sarmon, I'm gonna call those masters first wave. So we're second wave, and the difference is, and again, don't mean to usurp here, but just to get clear, everyone, the difference between second wave and first wave is strength and conditioning. We come out of strength and conditioning, and maybe we're third gen strength and conditioning coaches. Maybe you're like a millennial strength and conditioning coach, but I'm a Gen X strength coach, and think about where that was. That's Bart Starr is our go-to, Ripito, really those people, all the West Side kids, they did a lot to get us here.
Oh yeah. I mean, man, so much of the West Side stuff, so much of the Ripito, and seeing you alongside Mark Bell and all of that content for just years and years and years, it's just been so crucial to the development of how I see the whole MSK world, let alone everybody else. But no, I'm a proud millennial, and hey, at least you're Gen X. At least you're not a boomer. Is that kind of
that's right? People are afraid to come after the Gen Xers for this reason. We're like, bro, we had to make our own kettlebells. My mom was like, drink from the hose, swing in the street. That's how she was. I think you really just brought something up because I love the way you speak about MSK, and if you sit down next to me on an airplane, I say I'm a performance coach, and I don't even lead with I'm a physio, because that's really, I feel like, the formal training.
Yep.
I am a coach first and foremost, and everything is through that lens. And it's nice to be able to regress it all the way back to how do I simplify this to get someone out of pain and moving again. But I think through the lens of Olympic lifting, through the lens of sports performance,
I love it,
is how I understand the world. And I think that's really a big gap in people's understanding is I'm like, come with me. We have 800 athletes at this university. Come with me. These people are going to, if they're injured, they don't play. They're already injured, we're going to play. We are testing alongside really smart people who have their livelihoods on the line and Olympic medals on the line. And it's a part of a great conversation. And the conversation is performance. And out of that, we really start to make different statements about what we believe.
Yeah, honestly, in this kind of community or circle that we have, especially on social media, I hear people say, I know Dr. Locke says it, lose your religion. Especially he says it to a lot of new grads because you come out and you're identifying with like a cohort or a profession or a certain type of people. And it's almost that saying of, how do you know someone's a vegan or how do you know somebody's a CrossFitter? They tell you when they meet you. And so it's one of those things where it's trying to, like you said, man, a coach first and foremost. And then you start to see how, if that's the lens of how you are perceiving everything, which is your reality, it changes, man. Like, are we talking about biomechanics? Are we talking about vectors and force? Are we talking about applied physiology and anatomy? We're talking about these concepts, but have we felt them? Have we felt them first? We've been WhatsApping and chatting. We're talking about these concepts, and then you're sending me a video. Oh, I just asked someone to try this out. And we're seeing in real time how logic is making sense of A, research, and then B, what we've seen in our athletes and our patients. So I love what you said there. Real quick before we get into some more nitty gritty, we have a segment on this show and which is called Legit or Bullshit.
I know.
Okay?
I know. I'm sort of like dreading it. Here we go.
Okay, so I could not let you come on without doing legit or bullshit, but
Okay,
I feel like
okay.
I've given you some nice ones. Of course, it's meant to be provocative, it's meant to be hard, and it's meant to be short, sharp. So it's legit or it's bullshit. No ums, no ahs, no, give me context. Here we go. Are you ready?
Do it.
Massage guns for MSK rehab.
Bullshit.
Ice for injuries.
Bullshit.
The statement, as long as you adapt, technique doesn't matter.
Oh, bless their little hearts. Bullshit.
Static stretching.
Legit.
Using x-rays to determine postural diagnosis.
Well, do you own an x-ray machine? Bullshit.
Do you own an x-ray machine? The biopsychosocial model.
Legit, but not for the reasons you think. Poor way to describe the whole human.
TENS machine for rehab.
TENS, we're not talking about like NMES. We're talking about just TENS, not like Russian stem.
Just
bullshit.
TENS. Kipping pull-ups.
Oh, legit.
Nerve glides for pain reduction.
I'm going to go with bullshit because that's not why you should do a nerve glides.
Butt wink in the squat.
Do I obsess on it? No, bullshit.
Fantastic. That's it. You know what? I didn't ask about valgus. I didn't ask about flexion under load. I felt like that was nice.
Well, butt wink is a flexion under load movement. So if you said translation of your spine under load, I'm like, that's sketchy. Butt wink tells me a lot of other things going on. I use it as a great diagnostic tool. Did I answer those appropriately for our audience?
I think you did fantastic.
Just for example, I just left a university team. I just sneak nerve glides into a whole bunch of stuff. If you have a hook grip on a bar, that's a nerve glide, everybody. You elevate your shoulder, like it's all there. If you just flick your wrists while you're doing warm up.
Recently read in your course, it was talking about like nerve slide muscle stretch.
I think full disclosure, Michael Shacklock was an important keystone in my understanding of thinking about the nervous system as a very dynamic, non-stretching feature. And that makes it really simple to suddenly understand, hey, if that shoulder is translating forward, there's a whole lot of neural tissue in that area, right? Sympathetic chain ganglia. Look at what's happening there. And if it's stiff there, your T-spine limits how much nerve excursion is at the arm, and you're going to have to get it from the neck. When those pictures, the first time I was in physio school and I saw like someone bend over and get their brainstem pulled out of their skull, I was like, what's happening here? You know what I mean? This thing is designed to stretch. There's designed to be a lot of pull on it. And then there was a really important, the grandfather of thoracic outlet syndrome came to our school, and we had some patients who were very sensitized. And when you lifted their, contralateral leg, it would make their contralateral hand numb. And I was like, what is happening here? And that's when I started thinking, oh, okay, I understand. You got to be thinking about how the whole system slides and glides. And I think nerve tunnel, meat tunnel, I think is a cool term. Meat tunnel. If you're gonna have a punk band, it's called meat tunnels.
Yeah, didn't we come up with a great name yesterday?
What's your gladiator muscle name?
Man, yesterday we were yarning and it's like we came up with some good ones. Neutral cadaveric postures, and you said that's your new punk name. So I
neutral cadaveric posture. I literally was like,
man.
Wow. I
thought that was pretty neat.
All postures of a dead person are neutral. One of the things that you said, I want to just double click on. That Locke said that's so important for especially new grads coming in here is we want to show where we came from. It's really important because we can sort of understand the heritage of your thinking and why you're biased a certain way to treat. So my school was a heavy Maitland Australian manual school. That was like their Bible. The books, I still have the Maitland guides there.
Yep.
So I tended to go after joints first and fascia second. In my mind, if I could get a joint moving more effectively, I didn't oftentimes have to beat up the fascia as much. And I often found that in my practice, people were doing a lot of fascia and soft tissue work, and they weren't looking at some of the capsular patterns and the capsular restrictions. So that was just, and I just tell everyone, like, this is my blind spot. If this is working for you, do this, right? But what's happening now is I think one of my best coaches on the planet, one of my friends, his name is Yami Tikkanen. He's a one of the best CrossFit coaches in the history of the world. He's an osteopath. He's a naturopath. He's a doctor of Chinese medicine, and he's Finnish. And he and I think very similarly about the body. Our head coach is a chiro. So we can't tell what school you come to eventually, because you're going to talk about feet, you're going to talk about loading, you're going to talk about biomechanics, you're going to talk about, did this person drink water? Do they feel safe? Did they get sunshine? Right? You're going to talk about all that stuff eventually. It just turns out your school may have prepped you to do some aspects of the complete thinking and coaching of this person better than others.
Yeah, and every curriculum is going to have its strengths and weaknesses. Obviously, from that day you graduate is kind of the day you start on your journey of learning all this stuff, and the amalgamation of kind of this various types of information into your practice. Hey, so I've got a question here. So first question off the line: after such a successful and influential career, what is one piece of advice you would give to a new graduate that is finishing this month, today, next week? And we're talking, like we just said, could be chiro, osteo, could be exercise phys, could be physio, you name it.
There's a type 1 error in the question, that after a successful career. So I don't know who that is yet, because we're all beginning. No, I mean, this is not just window dressing. Like my friends, Stuart McMillan, CEO of Altus Track and Field, maybe the most legit, most decorated Olympic coach in Olympic history in all sports, has the most Olympic medals as a coach. Like that's how good he is. He and I are like, man, I don't know. Maybe we should just, I don't get it. I mean, we're running. Maybe he ran faster. We were shit in 2016. Like, and I'm like, didn't you win some gold medals in 2016? And he's like, yeah, but I was shit. I mean, so just everyone knows that this is when they say commitment to lifelong learning, this is literally two things. One, insane curiosity. And this is really difficult to maintain your curiosity. It's every day I'm in the gym. Every time I have a new warm up. Today I invented this thing with a water polo ball. We're holding the water polo ball and we're fighting for possession of the water polo ball as a way of getting primed for this UFC water fight we're about to have in water polo. And so I'm thinking like, hey, I did this with jump stretch bands. I didn't like that as much. Now I've got water polo balls. We always have water polo balls, right? And I could put athletes in different positions, standing, rotating, on their back, in flexion. Like we could just, and that's my hypothesis. And then I'm going to test it. I'm saying, man, I didn't get what I wanted out of it. Right. So I'm going to ditch it. So the curiosity means, and there's a fundamental framework I think that's really important, is that if you own this selfish position, that the person that you're working with in front of you is there to help you become a better coach, a better practitioner, you will then serve the next person and be less shit. And you have to apologize to that person. I know I was the best in the world, but that was yesterday and I was terrible. Today you would get something better. So this curiosity and this approach of that, I'm making this hypothesis and I'm open to change, and I'm open that there's a better way. I really am open. And I think what's really amazing is that the best coaches in the world, they're so good. They're masters. And it's not like 100%. Their humility is based on real practice and real outcomes. I mean, they can show you the medals, they can show you their thinking, they can show you what a session looks like. They're very transparent, but simultaneously they're like, there has to be a more effective way, a more efficient way. Let me give you a good example. Yep. One of the best coaches in the world, he's now usurped by a woman basketball coach, but he's one of the best, most successful coaches in the world, is Anson Dorrance. He's the soccer coach at UNC Chapel Hill. He's won more titles and he's just a mutant. He runs a practice now that's pretty tight and pretty progressive, and they fight and compete the whole practice. And it's 90 minutes long. In the beginning of his run, and this is in his bio, the women that he worked with would run an 800. And he was like, man, that's kind of a garbage 800. Like, we're not really running, we're not walking fast. They're just chit-chatting. It's a garbage 800. I wonder if I pull it out and do something else. So he pulls it out and the practices just go terribly, right? And because his hypothesis is this isn't getting what we want. Turns out he wasn't thinking about transition from being a student to playing. He wasn't thinking about giving athletes time to connect and to, see each other and get caught up and yarn. And so he was like, oh, that's got to go back in. And I think when you start doing that and you're transparent and humble about it, that'll blow your mind, because you're like, oh, that's such a good idea. And then you go around the internet and you talk to masters, or you travel, which is you're going to have to do if you want to be really good, and hang out with really good coaches and really good practitioners. If you show up at Luck's place, you can show up and watch him coach. Like I'm guarantee you, he'll be like, yeah, I'll be there at 5 a.m. He'll show up
Mm.
with coffee, and everyone is going to be transparent and show you what they're doing, and it's effortless. And when you start to see how people approach very complex problems with such humility, it's shocking. So that first, and the second thing is you got to be a really good coach. And
Yeah.
if you don't speak yoga, you go speak yoga. Go jump into some yoga classes, speak some fundamental yoga. If you don't speak Pilates, man, go and take a couple of Pilates classes. If you can't do some basic barbell lifts and aren't competent, if you feel like push press is over your head, you're afraid to swing a kettlebell, you need to go learn those things and go be a student in that system. Go jump into Pavel's strong first stuff, and you're going to be like, oh, so many good ideas here.
Yeah.
And so I think suddenly I can't point people enough at Joel Jameson. I think strength and conditioning has actually become strength and corrective exercise. It's no longer conditioning.
Yeah.
And
Yeah.
Joel Jameson is doing the best in the world at actually doing conditioning for athletes that aren't monostructural swimmers, bikers, runners. Like there's no one, so go jump into his Morpheus course, go learn a little bit. And suddenly you're going to be overwhelmed with
Yeah.
how much you need to integrate and synthesize.
Mm. So coming off the back of that, we have curiosity, humility, and showing your work.
Yeah.
And then off the back, Joel Jameson, key person to check out.
I think he's a great person to check out
Awesome.
for conditioning.
Absolutely. No, cool. Fantastic. I just wanted to get those down. How has your approach to MSK rehab specifically changed now compared to 10, 15 years ago?
I put a much bigger stock in tissue health.
Yep.
I think you, as a student, you come in and someone comes in there and they're like, here's your subjective interview. And you are really going to get to know someone. I'm like, what do you do for work? Tell me about that. Like, there's no way you can understand the context of what's going on in that person's life, their movement history, their injury history, how they move when they're fatigued, how they self-soothe. Like, I don't think I asked anyone about their bourbon drinking or their cook. You know what I mean? Like, there's a whole lot of things to unpackage. And so this is what Built to Move was really about, was being able to get to first principles quickly with people so that you could understand signal for noise. And I think there's so much noise, it's difficult to get the signal.
Yep.
The other thing I think, and I learned this very early on, I was treating at Kaiser, San Francisco, and I had this, it would take someone 6 to 8 weeks to be evaluated, 45 minutes. And I got 45 minutes because I was a student. It's otherwise it's 30 minutes. Yeah. And then, it would be 2 weeks for a follow-up. So someone's been going on for almost 2.5 months with their problem. I really started to think, what can this person do for herself between? So intercession versus intrasession change became the game. And that's why when people are like, man, manual therapy, I'm like, well, do you have time to do manual therapy and all these other things? Like, what's your problem list? And if this person's not sleeping, your PAVM is probably not as effective as you think it is, right? But simultaneously, touch matters, all these other things matter. How are you going to empower that person to start to feel like, holy crap, this provider in front of me has given me tools to let me have buy-in and control over how I feel. And most of the time when people start to feel a little bit better, then they're like, hey, give me more. So I think reframing what we were going to get done, and the fact that most good problem resolution does not happen in the clinic. It happens in the gym.
Man, so many nuggets there of wisdom. And I did want to just circle back around to this idea that as professions, we have these interventions that we're taught. You just right then, you talked a little bit about patient interaction, right? So how we are communicating, how are we educating, and how are we truly making change that's going to last? For me, one of the things I've really had to come to terms with is that aspect of communication when it comes to patients that are coming to see me that have had a long history with pain or dysfunction or lack of function, and how me as the practitioner or the clinician is going to kind of interact with that. One of the biggest things, elephant in the room, is pain. So for you, how do you best begin to manage your patient's experience of pain? And a sub question, do you use pain scales, 1 to 10, the kind of the Borg hypothesis, 1 to 10?
No way. And I don't, because it's so subjective. Some of the people I work with have freakish discomfort with discomfort, right? So I really am like, I start with the resting assumption that the resting state of the human being is pain free. That's
Okay.
our resting state. So it doesn't mean we're not going to train. I know your job is to, lift these boxes or run through this wall or tackle someone. And so we really start to reframe this narrative that, hey, this is an okay experience. And here's how we know when I need you to run this up the flagpole.
Yep.
Okay. And then simultaneously, of course, I'm like, by the way, have you tried these 15 things to make yourself feel better besides ibuprofen and bourbon? And the chances are they haven't done any of those 15 things, right? So there are some slow acting ones, getting some sleep, eating some protein, being hydrated, talking about how angry you are with your father. Like all of those things are going to take a minute. But then there's all these desensitizing things. And I use the word desensitize in a way that it's not a dirty word.
Mm.
If someone's like, coach, my shoulder hurts. Now it doesn't hurt. I just had a player today. Was like, man, my front of my shoulder is cooked. And I was like, lay down. Oh, you have no internal rotation. Let me just go ahead and restore this internal rotation. And that person slayed in this tournament and was like, hey, I swam faster and it was easier, right? And pain was the conversation. And so changing this narrative for a lot of our athletes, again, athletes who have some context, start to see check engine light. Hey, I can become curious about that. I know that I'm going to still be able to override that and slay. I mean, if you've ever been in a fight, you don't feel pain in the fight. So we can, like, when our athletes are in the game, like they feel great. I'm like, that's not gonna be a problem. A problem is afterwards. So
Yep.
we have I have a thing I came up with to help me systematize all the things that I was seeing that people could do to self-soothe. And I use that word. You can put placebo in there. That's fine. I'm down with that because, if you break the chicken neck and you rub the dirty chicken on your elbow and it doesn't hurt, and we do it every single time, I'm going to show up with the dirty chicken. So, but what we do say is desensitize. And there's a lot of ways we can desensitize that thing, right? Percussion can be a really great way, athlete driven, to suddenly make it so it doesn't hurt anymore. And then we can go do what? Move. Right. That's always the next follow thing. What are we doing? It's not about solving the problem. If you want to solve the problem, you're going to have to come to my gym and I'm going to have to teach you to use your body and to load your body and to develop all these systems. I'm going to teach you to sleep. And that's how we're going to get out of this. I mean, that is the fundamental lie about what we're doing. You don't get paid to restore someone's shoulder function. You get paid to get someone out of pain and doing their life independently. Sometimes that's workers' comp or work hardening, but fundamentally that is not your job. So stop pretending it's your job. If someone comes in and they have shoulder restriction overhead and pain with going overhead, and suddenly they have less pain, did you address their shoulder function? Do they have internal rotation? How about their shoulder extension? How about their T-spine? Did you do any of that? Because those are components to that movement system that you didn't even talk about. Did you load them and progress them? Did you leave them strong? So all you did now is say, well, now it hurts less when I do the same movement, or it doesn't hurt. But this is not overhead. This is complete overhead. So you haven't even touched full overhead range. You just have gotten, so understand that there's a distinction there built in and a bias that we don't talk about, that the treatment place, who is getting paid for that treatment, right? If the athlete is paying out of pocket, you're going to get and ask for some different results, right? If that person's part of a managed care system, don't pretend like you're putting them back out in the field with a stronger bench press and better long lever control. You didn't do that. You have a carpeted floor and a tile ceiling, and the whole system isn't set up to improve someone's function. It's set up to get them back into work. So that's okay. That's legit. So desensitize. What are the things that we could go into desensitize? Scraping with a spatula. That's cool. Percussion, cupping, voodoo. There's a whole bunch of things that you can go into desensitization, right? Then we say, well, D2, R2, desensitize. The next thing I like to say is, can you decongest it? Oftentimes we have people come in and they're highly sensitized because the tissues are congested. Why? They haven't moved it. They've been afraid to move it. They haven't loaded it. It's swollen. Whatever word you want to do. I saw an athlete today who hurt her arm on a lane line, swollen. The compartment is small. It's a small compartment in that forearm, right? And lo and behold, she's like, yeah, it kind of doesn't feel good, and it's a little achy, and you push on it, it's like a rock. And I'm like, well, let me introduce you to this thing you can do. It's called a voodoo floss band. Got the idea from Dirk Herzl, ran with it a little bit. We compress up. And she's like, well, how many times do I need to do this? Well, I'm like, first of all, just put it on, wrap it up, and then wiggle your hand around and try to restore some sliding in the tissues, right? And like pump it out. She's like, how many times do you do it? I'm like, whenever you want for a minute, and then just in between, whenever. And at the end of the day, she's like, what the hell? She's like, it's gone. It's the bruising has changed.
Wow.
Like, it doesn't hurt. I'm like, well, it was just congested. So all we did was say in our problem list, do I think it's weakness? Do I think she's disrupted a tendon? She get an x-ray? No, these tissues appear congested to me. What are my tools to decongest? I can do it manually, right? But here I have a young athlete who's able to do it herself. So we decongest, and we can suddenly, you're like, oh, maybe Normatec is not worthless, right? Maybe that's a great tool. Yep. Maybe walking is great. Yep. Maybe breathing is a way of decongesting the spine. Suddenly you're like, okay, what are all the tools that fall into that bucket? Then I like to say, can this thing benefit from perfusion? What happens if we flood it with blood? So suddenly it looks like bodybuilding. It looks like simple motions where we just get the thing engorged with blood. You get the garbage out, the groceries start flooding back in. Stop chasing pain. Perry Nicholson is one of my lymph ninjas, my senseis. Perry Nicholson, Stop Chasing Pain. And he will say and point out that a lot of tissue perfusion is rate limited by congestion. So we dump the lymphatics, we move that along, and lo and behold, blood starts crashing back in. Then you're like, well, what are the other things I can do to get it hot? I could scrape it. I could NMES and get some, some nitric oxide release. I could move it. Right. And the last thing in that list is restore range of motion, because no one talks about range of motion and pain. And I suspect that oftentimes when we restore someone's range of motion, some of the miraculous outcomes we've been seeing over the years that we've been doing this, decades, is that it may be simply, wait for it, everyone, the brain goes, oh, that's not the thing. Now we're doing a new thing, right? Maybe the sodium ion channel half-life is 24 hours, and then you just changed the range of motion and got off that ectopic depolar. Dude, we can play that game, but all I know is that you're supposed to be able to bring your hand to your face, and you can't bring your hand to your face, and all of a sudden you can bring your hand to your face, and then your elbow pain goes away. That's cool. So again, chasing the function, I think, is important. What's limiting the function? You can come up with that. But if you're seeing these big gross limitations in range of motion and the knee is swollen, eventually you should ask, well, if I'm managing that congestion, does that knee have terminal knee extension? Does it flex all the way? Why aren't we asking those basic things? And why are athletes still so in the weeds about that? Now we're like, man, percussion is dumb. I'm like, oh, that's not the question to ask.
Locke will often say, patients come to him, they pull up their scans, their head is in a whirlwind because they have a diagnosis, they have a label that they're holding on to. And he'll say, don't tell me your diagnosis. Tell me, what are your day-to-day problems? What are your issues? What can I help you with? What do you need to be able to do that you can?
How are we going to define success as a coach?
Absolutely.
Let's go ahead and define success. That's not a patient goal. That's success. When are you going to tell me that you want to fire me? Right? Now we're cooking. I need to add 100 kilos to my bench.
I like it. I like it.
I like that. I'm down.
Also talking about, strategies or interventions that we can use to downregulate, or with the sensitization thing, desensitize tissue structures or even parts of the nervous system. We have so many chiropractors on this platform, and Stephen being a chiropractor, me having training in that field. Obviously, spinal manipulation is a huge topic. Giles Geyer, who's one of the experts in research, he often talks about manipulation, not just being like a downregulation thing, but a short-term symptomatic functional neurophysiological change, like a window of time that you can now get people moving more. And I just see so many parallels between exactly what you're saying and exactly what he's saying. Whether it's pushing or poking or whacking someone over the head with a spade, you're likely going to get some type of neurophysiological change, which is just funny because people get attached to interventions. People get attached to methods of doing things. I love the way you're talking about it. You're like, can we floss it? Can we scrape it? Can we rub it? Can we add vibration? All these.
And when I say we, I'm talking about you.
The person.
I'm going to call, wait for everyone. Those things can be very skilled, but I'm going to call those things unskilled interventions. And this is going to, here we go on the internet again. If it's on Amazon, it's unskilled. How's that? If you can buy 1,500 versions of it on Amazon, that has become an unskilled intervention, right? So if you can get 15,000 gua sha tools on Amazon, I'm not sure. I need that probably belongs in the domain. And don't get me wrong, I see smart practitioners using a tool to solve a problem, to do what? Get someone moving again. And then look, what's so cool is I'm like, oh, I wouldn't have done that, but that's really clever. Look at their outcome.
Yeah.
I
Yep.
don't go and shit on them. I'm just like, huh, that's maybe not what I would have done,
Well,
but man, I want
they're showing their work. Hey,
showing their work.
which is what you were speaking to me about when we were chatting.
Yeah.
It's like,
Show
show
me your
your
work. Show me your
work.
work. So I think that's one of the things that we can be doing a lot better of. And HIPAA, I don't think anyone thought about TikTok on HIPAA when the first regulations came out about how should we protect people. We don't need to look. I work with a lot of people who get paid a lot of money to do a lot of things, like run the government, um, win Oscars, do all that stuff. I don't build my practice on them, but there's a whole lot of things I can show, and I've been doing that for a long time. And sometimes people are like, I don't care, let's talk about it. And or you can hide their face and like obscure every single one of the aspects of the discerning features of this person, and sort of talk through your narrative. And if you're going to do that, let's do it. And if you're going to go ahead and point fingers, show me the other side of it. And look, it is complicated because we're going to have styles, and it sounds a little bit like my kung fu hard style, your kung fu soft style, and like we need to rumble and have like a fascia off or a squat off. And I just don't. What I want to see is that you become curious. There's a whole lot of things that I might not choose to use because they're not my strengths. How's that? Right? There are these other strengths, and
Yeah.
I think that that's really important, and it really always comes back to that person moving through the environment, interacting in their environment, straight up. In fact, we've done is created. I read this book by Charles Perrow called Normal Accidents, and it's about complex systems theory. And his idea is that most systems are so complex and so tightly intercoupled that eventually you'll see some kind of thing happen that looks like a freak accident, but it's a normal expression of the system if you give the system enough time to express itself. So if you collapse your arch and slam your ankle down and you have island feet and you wear flip-flops all the time, you may not have a problem. We call that a trivial event in a non-trivial system. Nothing blew up. Your spine didn't pop out of your back. Nothing happened, but I'm going to see down the road that might end up being a problem for your knee. That might end up being a problem for your ankle. That might end up being a mechanism for a bunion. It might end up being, we don't know. We can just be like, well, we ran the experiment. And since there's so much time in between those things, we can't look at that. Or we can say, hey, here's some aspect of the system that we can improve. And the question is, if you're a coach, isn't that part of training where we're like, oh, hey, let's improve the system, right?
Yep.
If you're a physio, you may not have time, and that may not be the reason why someone's shoulder hurts. It can be a component of downregulation of the whole system, but are you going to chase the shoulder if you're getting paid to get that person out of shoulder pain or neck pain? No, you're not. So suddenly you're like, well, it doesn't matter. And it doesn't matter at low loads, low speeds, et cetera, but you can't say definitively it doesn't matter.
Yeah, so just to circle back on that, you spoke about desensitize, decongest, perfusion, restore range of motion. And what did you call it? You called it the
D2R2. R2D2 was taken.
R2D2 was indeed taken. You mentioned that you helped restore internal rotation of somebody, that a patient or a client that you were speaking to. And this leads me to the question, just you personally, because I know we're talking a lot about like generalities, but just with you specifically, like, do you use many hands-on modalities? And if you do, which ones do you use and why?
Yeah. Great question. First of all, that there's a time and a place for everything, right? And if I have a killer set of power tools, sometimes I need to use my killer set of power tools to pull up my belt and I get on that 300-pound lineman's hip and I do that mulligan and I, do hip quadrant like it's my job and I'm in that position and I'll stay on that until I make change, until I stop making change, right? Yep. And sometimes I'm like, okay, how are you going to manage this on your own? Introduce you to the hip capsule mob, right? Because we really want to look at internal rotation of the hip. And I don't think 90-90 gets us what we want, right? It's a great way of just touching around. But if I see a lot of people do 90-90 and they still don't have internal rotation, sufficient internal rotation of the hip. So what we're seeing then is, okay, now what is it about this person's movement or their sport or their life where we're continuing to see this thing show up? What is it about their lack in movement diet or movement richness? Do they not squat narrow? Do they not squat wide? Do they not take the hip into extension? What is it about that their sort of training of the body to maintain, and why am I having to keep going to the well on this, right? That's a question I could ask. And then that gets me again right back in the gym. Sometimes there's very quick restorations of position. It's just very quick. Something's stiff and then it's not stiff. Something wasn't sliding. It's not sliding. That sounds like Ida Rolf. If something's not moving, get it moving. If something's not in the right place, get it in the right place. And she doesn't mean like you lift a muscle up and put it down. If your hand can't get to the place, get it to the place. So, really quickly in sports, again, I'm going to go back to Altus track and field. One of the things that they were doing that Stu pioneered with Dan Pfaff, who are pretty impeccable legends in their sport, everybody, they do something called trackside therapy, where they moved the table right next to the 100 meters. So when athletes run past, they're like, something feels weird. And they come and they lay down on the table and they solve it together. And guess what they do? They go back and run it again. Yeah. And that's how quickly they've conjoined, how tightly they've conjoined test, retest, this treatment. Now think about the average person who says, hey, I have this problem and I'm going to do a mobilization. And then does that person touch that shape? Do they go back to their life? I just don't know. They left my house and I'm like, I don't know what happened to you. But in the gym, I'm like, okay, now the squat rack is right next to the treatment table. And now we can really understand. And it turns out, and this is crucial, if you can get someone moving without having to touch them, that's cool. Let's do that, right? And that ideally is what we should be doing. If we look at training as an opportunity to have people understand normative range and understand how to restore normative range within the training session. So suddenly we can say, well, training should be about, sports preparation, sports specific training, maintaining minimums, but also can be like, I squat to maintain this squat shape. I deadlift and hinge to maintain this deadlift hinge shape. If we get into the weeds and like push pull, when you see those lists, these are essential movements. What that means is you better approximate the tissues and you better traction the tissues. That's what it means. You better press something over your head and you better hang from a pull-up bar. That's all that means, right? So push pull. So suddenly what you see is, hey, I can be exposing people to these fundamental shapes in the context of what they're doing. And what I'm trying to do is get it so that athletes understand and can communicate their movement limitation language to each other, and they don't need the physio. The physio can then go out and do what? She can go out and manage the complex injury that is skilled care. The rest of this I'm going to call strength and conditioning. So we're having all these physio things, but I'm like, they're really strength and conditioning conversations. The strength and conditioning coach for me is the heart of the matter and the center of the whole nerve plexus. They are the only people who really know the athletes and know the session cost from the sports. So basketball coaches are trying to get their basketball players killing it. Then all of a sudden they come in and they see the physio who's managing a hot tendon, dealing with a tissue, right? Getting them to like give some treatment so the person can do their job. Who is looking at position? Who looks at all the things in isolation in this very simplified system? That simplified system is strength conditioning. It makes the invisible visible. That means that we need to give those coaches the power to see movement restrictions in the context of what they're doing every day. They'll know how they change. And then they suddenly have a set of power tools where they're facilitating the athlete changing themselves. And they all happen to be analogs for nearly everything you can do. Basically, it's hard for me to get on my C1. It is. It's hard for me to reach in my butt and grab my own coccyx. Everything else, I pretty much can do myself.
Yeah. That's interesting. And especially talking about some of the follow-up with an athlete, and I'm going to speak to more general population. A lot of what I'm seeing is like chronic pain, chronic issues, lack of function, general pop. And I'm thinking to myself, how can I get these people to move better? How can I know what they're doing when they finish a session with me, because they're going to go back to their life. Sometimes we'll do a journal system and they'll be journaling what they do and I'll be going through their journals. But I've been implementing on top of the clinical sessions, movement training sessions with my patients where I have more time with them. And all this is this S&C, strength training, movements, basic biomechanical stuff, but with more
regression and progression. We just box squat 3 inches.
Yeah,
but we're box
with
squatting.
a general population, and the hardest thing I find though is that they initially, at some point they're gonna walk out of the room and go back to their normal life. So for me, it's like you've got all these variables. When a patient walks through the door, how do I start to control for some of these variables and understand how this person moving? What are they doing 24/7? What are some of the things that I can fix and change? And when I've dealt with patients that have been to other clinicians before, that's one of the first things I think about. They come and see me. I've been seeing this person. I've seen this person, and I'm thinking, man, they've been to see some superstars. So what am I going to do that's different?
Yeah.
And then I start thinking something's been missed. How do I find it? And
That's right.
I love how
By
you talk
curiosity.
about taking people into the gym, taking patients into the gym, and outworking these small hypothesis per at a time. Hypothesis, test, retest, hypothesis, test, retest. You got people that sit behind a computer, keyboard warriors, and they read systematic reviews, and then they go online and they start spewing nonsense. You get these comment frenzies, and we talk about this recently. The idea of, okay, science is saying one thing when logic may be saying another, and then we're left to reconcile these two things as clinicians,
Right.
therapists, and strength coaches.
Tricky.
It's a bit of a mindfuck.
It is. And, ultimately, I believe in, and this worked for our setup. We have a huge gym. We had a gym closed in the pandemic after 17 years. We got crushed. Our overhead was just a mere $25,000 a month. And, when the gym closed, it was as successful as it had ever been, making the most money ever been. But we were paying $25,000 a month to not be able to occupy the gym.
Yeah.
We call that flattened by the curve. And, one of the things that happened though, is we had an open treatment model. And we actually don't have big permanent plinths. We have, because that's not our treatment style. We all can do grade 5. We all can mobilize. We put the tables in the corner, and when you need a table, we pull the table out.
Oh.
And treatment looks like this is an athlete being treated by a coach. And the coach may be a physio, but they're also a coach. And that person may be getting some and both, or neither, or some, and that allowed us to have this real porous door between. So imagine we have 6, maybe 7 physios at one point. We have a massage therapist at one point, right? Working in a gym with Gen Pop. So at some point I'm like, hey, I did live this life. It's 17 years of this life. My gym didn't have a physio there who also was a coach. So that was one thing that we were strong about. You couldn't be a physio at our gym unless you could also teach the basics of our courses, or of our daily training, right? You may not be the best in this, right? We had national champions of Spain. We had Olympic lifters who would go to coach in China. We had world champion strong women. Like our gym was chock full of superstars. And, if you needed someone, you would turn and be like, oh, you need to go talk to this person about that. Oh, you should go talk to this person about that.
That's so cool.
Oh, and that means that person, someone would always be like, I need to work with you, Kelly. And I'm like, well, you don't, because it's just, you don't, it's not that complex a problem, but why don't I start and then I'll hand you off. And I was like, and I'm always going to be here. So if we have a question, we can just all collaborate. People are like, that's great. They just don't know what they were getting. And then what's really important, and I think this is so weird, like all of these hidden sort of backdoor conversations about some of the aspects of our training, or the aspects of our treatment and our practices, or the industrial physio chiro complex. Imagine doing anything without knowing who you're getting. The referral process is, you just were like, my doctor said, go here, and my insurance said I could take my thing. Who is that person? Like, what? Are you serious? Like, what are their outcomes? Who they're treating? What kind of people do they specialize in? Like, if you're a runner, let's go see someone who kicks ass with runners and gets runners back fast. We were right next door to an incredible full-scale physio-only complex called Presidio Sport Medicine. Chris Chorak was one of the early pioneers of this model in the Bay Area, and one of the few women-owned physical therapy practices early. So shout out to my homie Chris Chorak. And when people had injuries and they needed a tissue babysat after reconstruction, repair, something like that, we were like, why don't you go spend all 10 of your credits over here doing this low-level cookie cutter bullshit? And when you're done, come over here and we'll go. Because I'm like, you're Right now, we're just babysitting this tissues during this healing phase, right? And we just can't really, we're not going to do a better job than they are with sort of this setup. So keep that in mind that, almost we should be bucketing who goes where. And are you just seeing, pointing your finger on the map and then walking in? I mean, like, theoretically, every physio should treat everyone, but I'm telling you, that's not appropriate. It's not appropriate. And then second is making sure that, what we're there for is skilled care, and no disrespect, but seeing someone after total knee replacement, for us, that became a meme. If someone specialized in total knee replacement, total, arthropathy, sort of replacement care, they had given up on being a physio. They were just interested in punching the clock because it was so like, now we bend the leg to this degree. And then, and again, there's a lot of creativity and brilliant people there. Yeah. But our idea is, hey, how do we make this a skilled care again? Now I'm going to blow up physio for a second. We are in a model where we're like, I, as a physio, want to have an hour with my patients, right? That's great. That is a weird model where the dentist doesn't do that. The doctor doesn't do that, right? I need to be overseeing the care. And what we saw was that we could get our coaches spun up to help the patient, help the athlete manage congestion themselves, decongestion, desensitization, right? Mobilizing. And then we could come in and support that athlete with a coach, or do the manual work, or have the complex conversation, or get the referral, do those things. But really I think is that there's a whole lot of low level things that have been taken off the table. And a lot of people got paid a lot of money for a long time doing those low level things. And if you look at like the new rehab science book, right, you're going to see it's every page, every set of worksheets given by every physical therapist to every patient is now in a book. So if you don't need those, you're going to go home and get some stick figure drawings of clamshells. Cool. Then we can have the real conversation. But what it means is we get to really start to decide what's skilled and unskilled.
I like it. We have ran out of time because I want to make sure that we finish nice and straight for you. But I have so many questions, but we got what we got was fantastic. I'm very appreciative, and I just want to quickly comment on that last piece you said. Having a gym like that and having a referral network like that is so cool. And under David Johnson, a neurosurgeon out of Australia, we've created an online alliance worldwide called the CFMC, College of Functional Movement Clinicians. So people listening to that, if you want to get involved, you can contact David Johnson or message me. And a lot of it is similar to what you're talking about there, Kelly, and especially when looking to hire people to be like functional movement coaches. It's like, okay, do you have the education squared away? And then Dr. David will say, do you have calluses on your hands? So it's like, it's this thing.
I just want everyone to know I've known David for almost a decade.
Yeah, he's fantastic. And
he's fantastic. And it is difficult to say, hey, let's look at how people are moving and let's put that first. And however, what language you want to hang on that, if we're generous towards people, it's easy to get caught in the weeds. And I think the reaction of spending so much time in the gym and hyper analyzing I'm like, have you ever just taught a beginner how to deadlift? They're going to round. Like, that's okay. Right. And then we work on it and we use that as like, hey, your technique is no longer supporting the load. It was stable, changed. Great. You know what I mean? We didn't say you can't ever lift that because you rounded. I mean, if you ever worked with an athlete, ever taught anyone anything, we make a lot of mistakes. And we do a lot of movement that's less effective at getting the load done. But the old model has to die, which is throw the eggs against the wall, and some eggs break and some eggs don't. And we take the broken eggs and we were like, good luck, maybe you'll get further next time. That was literally the Olympic lifting model until like the 2000s. I know, I hung out with those guys. We were talking with Penley, we're talking with Dave Spitz. Like, we saw that they would get their athletes so far and then something would happen. Ask Travis Mash, he's gotten religion on these things. And it's because we now have a better way of really looking at, hey, how do we get the most out of this athlete? And how do we decide as a coach when we've exceeded those expectations?
Hey, well, thank you so much, Dr. Kelly. We are so appreciative for you to coming on the podcast. We would love to have you back, but I'm sure people that have listened to this podcast have got lots of little nuggets. So thank you so much for your wisdom, your time. We very much do appreciate it.
My pleasure. And everyone, I'm getting off because the Niners are playing right now, who happen to be a Ready State team. We happen to have trained all of those coaches and how to understand a strength and conditioning coach. Shout out to Dustin Perry, who has created one of the greatest strength cultures on the planet.
That is pretty cool. All right. Thanks, Dr. Kelly. Appreciate you.
Thank you all.